I'm lucky enough to have a world-renowned supermodel, icon, idol, teen idol, also very well known for surgery, Dr. Ritu Chopra. Dr. Chopra is located right upstairs from me in the Roxanne building. He is a plastic surgeon doing a lot of facelift stuff and lots of breast stuff. So he's kind of the go-to, I'd say, for Allergan for all their lovely implant, explant stuff that's been going on. And if you recognize his face from obviously like fashion magazines, but also
I think you've embellished just a little bit.
it's fairly accurate.
Yeah, okay, very accurate.
All right,
yeah, you're absolutely right. So it's interesting, like you said. Well, first of all, let's talk about how I met you. I just came down and met you, and you were literally one of the most normal people that I've ever met, who's also cool, super talented, and willing to show stuff. And so, you don't really meet friends when you get older, but I mean, me and you clicked and it's been a really great relationship so far. So I'm just grateful for that.
Yeah, me too. No, it's awesome that anytime we like hang out in the middle of the day, it like makes my day go faster. So it's really, really nice because I don't get breaks. We never get like lunch breaks and stuff. So it's really nice to be able to hang out with each other.
Absolutely.
Yeah, so I got a lot of questions for you since this is not my world. I only know like here up.
Right.
And I've only like experienced breasts socially. It's not really a work thing for me. But we're going to really get into the wide world of explants and breast illness and that kind of stuff. But the first thing I want to see, since you've done so many revisions and explants, and you do face stuff too, when patients ask you, can you reverse my surgery? Is that possible in any way?
Meaning reverse my surgery from a facelift or from a breast point of view?
From either. Can you put me back exactly how I was?
No.
Okay. Well, I tell them the same thing, but
it's
what
very
do you tell them?
difficult because once someone's been in there and rearranged their normal anatomy, it's very difficult to do that. Obviously, we're taught to recreate the deformity, right? So we take everything down and we look at it and see what's left. But it's very difficult to go back once you sort of messed with it,
Yeah,
especially faces. I think faces are tougher than actually breasts. Breast you can mold because there's tissue to mold.
I tell my patients the goal of any of the surgeries that we're doing is not to return you back to what you were. It's to make you better from this point. So, and I'm not, some kind of creative genius that I could figure out how to put everything back to how it was. You've aged since then. Things have changed surgically since that time. So I tell them, I'm going to do whatever I can do that I can imagine from this point. I'm looking at you now. So showing me your old photos, sometimes it helps give me some input. But I'm not using them to look at a guideline of what to return you to because I can't return you to that. So not being able to return. So, yeah, go ahead.
No, I think you're right. It's just getting the patient's expectations in line with what you can actually do, right? It's the doctors who don't do that have those bad outcomes, and they come and see me and you for revisions.
Yeah, and when you see people who come in, patients, especially recently, trying to remove implants or do revisions, what are the main reasons nowadays, like the past couple of years?
Yeah, so it's interesting. The last 3 years or so, my practice has sort of changed, So I do maybe 40% facelift and about 60% very hard breast revision and explants. As you know, I'm doing 4 or 5 explants a week. And the main reason women are coming in right now is twofold. One, a lot of women are just tired of having implants in. Right? They're like, I'm done with them. I had a great time in my 20s and my 30s. And I'm like, I'm good. I don't want them anymore. And the other set is patients who really have breast implant illness. And that's a super controversial topic, at least in the plastic surgery field.
You know a lot about it. So what is breast implant illness? And does it exist with other things in the body?
Yeah, so breast implant illness is a conglomerate of symptoms. Right? They can go from fatigue to hair loss to joint pain to rashes. All of these things can be associated with other things. It can be associated with vitamin D deficiency. It can be associated with lupus. It can be associated with rheumatoid, any autoimmune disease, right? So essentially these symptoms are characteristics of something's going on with the body as a whole.
And to be a breast implant illness doctor, do you think you have to be a little kinder and nicer and more understanding?
Yes.
In the way you talk to patients, and why? Why do I even bring that up?
Well, because I think you hit it on the head, right? Because the tide's turning, but you used to go to plastic surgeons and they would blow them off. You're like, oh, no, you're crazy. It's all in your head. It's your hormones. You're getting older. It's your age. And they wouldn't listen to the patients, right? We've had this issue from the 80s when they took the implants off the market back then, right? And they're the same sort of symptoms they're complaining about. And so you have to just listen to your patient, just like in any field, but especially with these patients, they want to be heard. They're really having symptoms and they feel like shit.
I've heard of different reasons as to why this happens or why people think it could happen. Like I've heard biofilms and reactivity, allergy, reactivity after you have encapsulation. I've heard like a million things. How real is it from what you've seen, and what do you think actually causes it?
That's a great question. So the interesting thing is, I've done hundreds of these explants, and I can tell you anecdotally from my patient set, about 90% of the patients are feeling better after I take out the implant, as well as that capsule, the scar tissue. In fact, we took all my patients, I took some of my patients, we took 50 of my patients, and we looked at them over 6 months, and we actually found that to be true. That's actually going to be presented at the ASAPS meeting, which got canceled. So they're looking at it, they understand it, and we're going to be one of the first papers that are showing what's really going on. And so why do people get this? We don't know. We don't know the real reason for why people are getting it. We need more research in it. Do I think it's biofilm? I think that may have a little bit to do with it. Why don't I think it's the main reason? Because when I take out those capsules, I test the capsules. I swab the capsules for bacteria, and I swab it for fungus, okay? And I don't get that many positives back. I get some for P. acnes, which is a big contributor to capsular contracture. I get some sort of skin flora and things like that, but I don't get bacteria every single time. It's maybe 10% of the time. What I think's going on is this. I think there's a subset of women who shouldn't have implants in. I think they're reacting to the outer shell of the implant, either a saline implant or a silicone implant. It doesn't really matter because the outer shell is essentially the same. So the issue is we can't pick out the women who are going to have problems with it, because it usually happens 6 to 8 years later, but I've seen it as early as 2 years.
Yeah, so I think regardless of the cause, and I see this in the face too, anytime you put a foreign material in there, it doesn't matter if it's inert or encapsulated or anything, your body can react to it. It's ignorant to think that it can't. And it doesn't matter if you can identify the root reactivity or a delayed type hypersensitivity or look for eosinophils in the blood or anything. Any foreign material in the body, your body can recognize and react to, especially if it's this big.
Yes.
So,
no, I think you nailed it, because if you let's look at textured implants. What's the thing? It's a T-cell lymphoma, right? Mm-hmm. You look at the women who have rashes with implants.
Is that what the recall was about for textured implants?
Yeah, anaplastic large cell lymphoma. It's a T-cell lymphoma. It's not a breast cancer. Mm-hmm. It's a lymphoma. So, but it's a T-cell mediated reaction, right? So it's your immune system. Same thing goes with rashes. When people have rashes with these implants, they're usually T-cell mediated, right? So I think it's a T-cell mediated thing that's going on. It's just like the analogy I use to patients is someone who has gluten sensitivity, right? We know the people who have celiac disease because we can test them with an antibody. Mm-hmm. Then there's millions of women out there or people out there who we give them gluten and they just don't feel good. Right. Same thing goes for these people with implants. We put in implants, they just don't feel good. We don't know why. There's no tests we can do, but they don't feel good. It's very, analogous to that.
Yeah. And I myself, so I dated a psycho and had my rash. You remember?
Like just one psycho?
Yeah. But you remember I had those hives
totally.
for 2 months when we were hanging out. So I had hives for 2 months intermittently, just because my body felt a stress that I was not aware of. I feel as though a filler can do that. Mm-hmm. Any kind of material, even this much that's sitting in your body, it can cause a stress in your body if your body doesn't like it. And we don't necessarily have to quantitate it or be able to test for it or anything. it's possible, and it's not remotely possible. It is possible. Your body can just have a stress, and you can get hives from these things just from having that stress. And I got it without an implant in my body. Like you can
Right.
definitely get it from having something in your body. I don't know what it is. Now, obviously, I think a lot of doctors scoff at this because you can't prove it, and there's a lot of other factors that could be involved. And again, I'd be scared to have your job because it's kind of like treating fibromyalgia sometimes.
Totally. A lot of women have this fibromyalgia with it, right? So the interesting thing is, let's look at it from an outside perspective, total outside perspective. Why would a woman want to come to me when they like their breasts generally, have their implants taken out, have the capsule taken out, which is not the most pleasant thing because they have to peel it off the ribs, and maybe have a lift so they add scars to it, and then have to pay me for it? Why would all these women want to do it? It's not because they're crazy, right? It's because they don't feel good.
What's your success rate with removing it? Whether it's a psychosomatic thing or it being an actual physiologic issue that's going on, what's your success rate?
90% at least.
That's incredibly high.
Incredibly high. So even if it was placebo, let's say it was placebo, God bless them that they're feeling better. I'm happy to make them feel better.
Yeah.
Right?
And you made them more natural anyways, less implant.
Right.
So,
and they never have to worry about implants again. And listen, I'm not saying everyone reacts to them. I'm not saying that at all, as you know. But I'm saying there's definitely a subset, and it's growing larger and larger. The issue is that women haven't sort of correlated all their symptoms to possibly their implants. So what generally happens, a patient comes into my office and they've seen every doctor in the world. They've seen a rheumatologist, immunologist, plastic surgeon, general surgeon, and they're all like, you're great. All their lab tests are generally normal. But they feel terrible. They come in and I don't want to be dramatic, but there's women who are coming in and saying, Doc, I feel like I'm going to die. I need to get these out. And they sort of inherently know what's going on in the body. Women are very intuitive.
Yeah. And I would say there is no significant reason not to remove them other than having trouble kind of reconstructing or lifting or anything like that. But I'd say a big message to the doctors would be that don't dismiss it. It's possible. Either way, you can take it out. And a message for patients is, yeah, it's possible, but don't think that necessarily this is what's causing your problems.
Absolutely. So there's plenty of women who come into my office and say, I don't feel good. I'm having this and that. And I said, you probably need to go through the steps first to figure out what else is going on. And this is sort of our last resort. So I have them go see a rheumatologist. I have them get checked out by everybody. Have them get an MRI. Have them get all their labs done. So by the time they come back to me, we've ruled out mostly everything.
And this is just the last thing that you'll try. And you really have to try it to see if it works. It's not that you've diagnosed them with breast implant illness and said, listen, this is what you have. It's more saying we've tried everything else. It's possible that this is causing the problem. I want to make sure it's not something else that we need to fix. And if you're okay with it and everything else we've tried, and this is really, the last effort, and you really even want them out anyways, then let's go take them out.
That's right. And so that's what I say to everybody. I say, taking these out, there's no guarantee your symptoms are going to get better. But at least we've ruled this out.
Yeah. And even for patients who you took it out of and they feel better, you say, bless you, I'm happy it worked for you. I still don't know if it caused it. It's
right.
problems.
Right. So. But obviously, there's something going on with these women.
Yeah. I would say there is something definitely possible. And from what I've seen, even from smallest fillers, I'd say don't dismiss it for other doctors who have kind of seen.
Have you seen anything with silicone nose implants that, the Japanese use and things like that?
Well, the body usually just kicks them out directly. So as soon as it gets irritated, even if they get hit, like tapped maybe 5 years later, that can awaken the body to the fact that there's a foreign material there. And at that point, they start to extrude it. Not from the trauma that's eroding skin. It's just that the trauma woke the body up in that area. It heightened the immune response. And all of a sudden, the body starts to recognize there's something there and then starts to kick it out.
That's an interesting point, because what I've seen is women who come in who have saline implants, who want them switched out to the silicone. Those women will start having symptoms because, like you said, we're sort of waking up the body.
Yeah.
To that area.
Yeah, it can definitely happen. It can happen with fillers under the eyes. You had a filler, let's say in 1995, and then the year 2000, it wakes up again. In the year 2004, it wakes up again to the body just being aware that it's there. And you have to, patients have to realize that your immune system is working at all times on every cell in your body.
Yeah.
You can easily go operate on one area, touch one area, injure it somehow, and all of a sudden your immune system has now been awoken in that area and will start reacting there and replacing cells faster, immune and healing, but faster and in a higher concentration than it is to the rest of your body. So if you were to do like a PET scan, you see little tiny areas
lighting up here.
Yeah, little glucose isotopes kind of like, lighting up here and there. And that happens after anything is done to your body. And a surgery, if you do it, I'd like to tell patients, if I operate on your body, a little cut, at 1 year, 80% of it has stopped modulating. But at 3 years, 95%. At 5 years, who knows? I feel like the body heals with a sine wave.
Right.
And in the first couple of weeks, it's a big sine wave, big fluctuations, less and less and less, until it tapers to this little tiny thing towards 5, 6 years, 7 years.
Yeah, the implants is an interesting thing because, and what do you think from a philosophical standpoint? Let's talk about that. If you knew that you couldn't predict what patients would react to this intervention you were doing, how would you approach that?
I mean, that's tough. I would include that into my normal conversation of risks when I'm doing it, because I would assume that 99% of patients plus would do fine. So it's not a reason for me not to operate on them, nor would I ever expect that I'd ever be able to predict who's going to have it. So I just include it and say, this is your healing time. This is what goes on. And just to be aware, sometimes in the future, there is need for revising, and that could be for any reason. It could be because your body doesn't like it. I don't have to say breast implant illness. I'd say because your body doesn't like it, because you have a reaction to it, because you encapsulate. There's a million things that can happen, and when those happen, we deal with it. I think that if there were a proven permanent sequelae from this, so if you knew for a fact that breast implant illness was a thing and you could identify it afterwards, even by some kind of biopsy, let's say, and then you go take out the breast implant, you take out the capsule, and then they're still left with a lifelong problem, that's when you specifically have to have a conversation about breast implant illness with everybody. But that's not really the case. So I would kind of just include it in the general vagaries of what possibly could happen.
Right. So that's very interesting. So I think that's where we need to get plastic surgeons to. We really need to give them total and complete informed consent. That's the key, right? And people aren't doing that. You need to tell these women, number one, that these aren't lifetime devices, right? You're going to need more than one surgery for sure. But two, there's a real chance, there's a chance that you can really react to these. And they should know that before they're putting something into their body, right? I think that's fair. And for me, I've been in this quandary, and I've sort of said, listen, I'm not putting in any more primary breast augmentations, right? If someone has a problem with some implants someone else put in and I can fix them and help them, that's okay. But I'm not putting primary breast augmentation in anymore because I just don't know which patients are coming in. And since I'm seeing so many explants, that's sort of my world now. And I see all these women not reacting well. So what will I do for those patients? So I'll do sort of what we call a natural augmentation, natural breast augmentation, which everyone can do. A little fat transfer, grab some fat, put it back into the breast, and maybe do a little lift. And I think a lot of women will like that.
Yeah, and just to clarify for everybody, you're not saying don't do breast implants or breast augmentation, just your practice has now turned over that way, and you're kind of this nice resource for patients to do explants. So when they come to you, you don't even try implanting again. You just
totally, because that's right. Because you would feel the same way if you're seeing 20 patients a week not feeling good with implants. It's hard to sort of make that okay. At least for me, it's hard to make that okay for myself, right? There are surgeons that do, and that's fine. I'm not saying don't do it, but for myself, I just feel like that's my road.
Yeah. You're the person they should come to take it out, and then get better. See if it gets better.
Exactly.
Yeah, and 90% is pretty high, and I'm sure to get to that 90%, you do a lot of selection. Like you do talk to the patients, make sure they don't have something else going on. Make sure they're again not the fibromyalgia patient that you can never cure.
Yeah. So here's an interesting thing, and I think you'll find this very interesting. So there's been a bunch of patients who've come in with positive rheumatoid, positive lupus titers. We take the implants out, take the capsule out, we test them. Capsule comes back with chronic inflammation. The bacteria comes back negative, fungus comes back negative. So nothing huge. We retest their blood in about 6 to 8 months. They're feeling great. No more rheumatoid levels, no more lupus levels.
How many people have you done that on?
So I've seen about 10, 12.
So,
doesn't mean they don't have it.
Right.
It means that their immune system has
calmed down. Their immune
That's
system
right.
has calmed down. Yeah.
That's right.
Yeah. So I agree. And for people who, again, are scared of implants or think this is like the worst thing in the world, no, this is a very small subset of patients we're talking about. It's just that Dr. Chopra is a sub specialist. Like people come to him from everywhere to get this taken care of. So for him, it's his daily life every day.
That's right.
Me, I'll never see it. I just do face.
Well, no, that's right. Because, I went to Dubai, 3-4 weeks ago. And what were half of my cases? Explants, because they found me that I was going to Dubai.
Yeah. Right. Yeah. And that's awesome. What do you think about, since you're doing a lot of this natural breast rejuvenation or kind of contouring, and this is a question I have for like multiple people, can you do a substantial breast lift without cutting the breast?
So it depends on how much ptosis they have. And ptosis depends on where the nipple is. And I often tell women, you can tell how much lift you'll need by looking at your breast in the mirror and looking where your nipple is relative to your fold. If your nipple is below your fold, you're going to need some sort of lift, right? And so then there's different types of lift. There's a Benelli lift, which just goes around the areola. There's a lollipop, which goes around the areola and straight down. And then there's what we call a wise pattern or anchor pattern, which goes around the areola down in the crease. That's sort of the most lift to the intermediate lift to a baby lift.
And have you seen, so for people with drooping breasts, have you seen the internal stuff ever work, meaning that they just go in and put some pexy stitches here and there or threads in the breast?
Yeah, so no threads. I'm not a big fan, as like you're not a big fan of threads in the face, neither am I. But so they don't last. But you can what we call auto-augment the breast. So
that's what I'm asking. Yeah, so what can you do and what can't you do? So threads, no. But
yeah, threads, no. So you can definitely auto-augment the breast by dissecting the breast parenchyma out and rolling it under the nipple and tacking it down to the chest wall or the ribs and give you a little more upper pole fullness. Interesting thing about that. So they look beautiful on the table, right? Because they give you a lot of fullness, but there's been some good studies showing that as we age, it kind of gives up, right? Because gravity always wins. What can we do to help that? Well, there's different types of meshes that we can use to actually hold up the breast tissue in the right place. So that works great. Something called Galaflex that I've been using. I'll do the breast lift, and then I'll put that mesh like a hammock to hold my repair where I want it. So that works good.
And then when you're doing breast lifts, the biggest issue I've seen with patients who don't like their breast lift is either bad shape or bad scars.
Yeah.
So, how do you prevent the bad scars on a lift?
So, as you know, tension, right? So if you can take out all the tension from the skin, that's what you really want to do. And that's mobilizing the flaps, making sure everything is not tight at all. If you can do that and do a layered closure, that can help. And then you have to have a sort of a regimen of what are you going to do afterwards. So for me, I use Dermabond or glue for about 10 days or so, switch them over to micropore tape for about 3 to 4 weeks, and then I finally switch them over to silicone gel.
Okay, so you do a lot of like supportive stuff outside also afterwards.
That's right. And then IPL laser for the red.
Okay, so do you do any other kind of lasers for these?
Yeah, sometimes I do CO2 laser, depending on what they look like. And I also have been doing sort of microneedling if they're thicker and things like that.
Oh, okay. So the microneedling seems to work.
It does.
For the thicker scars?
Yeah.
Okay,
exactly.
So I've seen that actually. the kind of mechanical breakup of the hypertrophic areas. It's a nice, easy, kind of natural way to do it. Totally. And then you could do CO2 also. The issue I've seen or heard of with, and the reason that's good if patients don't understand, is that it's a very risky area if you're on the bottom of the breast to inject 5FU or Kenalog. You have to be very cautious with it there. The 5FU, if you inject it into an area that's high tension right under the breast, it can just break down and open. And the Kenalog can just cause discoloration, although you can still use it.
Right. So I've had a couple issues with both Kenalog and the 5FU. Kenalog for sure can thin out the scar, and then you're left with this better scar because it's not thick, but it's wide and thin, and then it's hard to revise that.
More of a big stretch mark.
That's right. And so what's interesting with 5FU is that I've injected a couple people, and they've actually had a reaction to it, and they got hyperpigmented. Have you seen that?
You can get purple discoloration from it.
Yeah. And so that's what I've seen. So I've seen that all the way across, and that's a difficult thing to treat.
Yeah. The problem with once you get that is that if the 5FU worked, it also thinned out the area and it becomes this atrophic scar. And if it's an atrophic scar with vessels in it, the second you hit it with a strong laser, whether it's a V-beam or something like that, it can kill the blood supply. So it's a bit risky. You have to make sure it can tolerate that. That's the problem with trying to get rid of redness on an atrophic scar.
Right.
You can just kill the blood supply right away because it's such a thin sheet of vessels going through that.
Yeah. And then to your second point about shape, right? So depending on what lift you do, you can end up with sort of a boxy shape, right? Mm-hmm. And that's what women hate. When they do that anchor scar, oftentimes women end up with a boxy shape. There's things you can mitigate that. But again, that's one of the things you have to talk to them about before you do it. So, there's a chance they can end up with a little bit of a boxy shape. We do everything we can to sort of help that. Mm-hmm. But it's one of the risks because of the actual geometric pattern of it.
And what's the rate of revision on just primary breast implant versus a breast lift? Because I try to explain to patients who jump into these surgeries saying, oh, I'm just going to go get a breast lift. I'm just going to get a breast lift. I'm like, well, do it if you need it. Don't jump into it. You got a lot of cutting to do. What's the rate of revision on a primary, on a person who's coming in for the first time for just implant versus actual lifting?
Yeah. So let's break it down to implants, lifting, and lifting with implants. Implants by itself is relatively straightforward, depending on, your dexterity and depending on how many you do. You talk to Ash, he does a ton. I'm sure his revision rate is relatively low because he does the same thing, every time. So he has a pattern down, and I think that's what you need. So revision rates for breast augmentation alone are relatively low. Capsular contracture, infection, implant malposition are the big things. Mm-hmm. I think that happened probably 11-12%. Let's go to breast lift. Breast lift, it gets a little bit higher because you're dealing with scars and you're dealing with shape. So the more scars, the more chance you need to revise them. That doesn't mean you need to revise the whole thing. You just need to revise maybe the scar. Mm-hmm. My revision rate for across is probably, 5-6%, depending on what it is. And that's all comers, even taking someone just to get a little dog ear out in the local room. Yeah. Right. So it's not very high. But when you combine a lift with an augmentation, that's where it's difficult because you're fighting yourself. You're tightening the skin envelope, but you also want to push out and get more projection. So those are can be difficult things to do, and it gets symmetry as well.
And you feel like your revision rate's lower now than it was in your second year of practice?
For sure. Yeah. I just think it happens, right? I mean, what about you for your facelifts?
Facelifts never had a high revision rate. The rhinoplasties, my touch-up rate has gone so low now for the past 3-4 years. But yeah, it changes so much. And anytime patients have to realize too, if you're going to a good surgeon, they're going to be changing their techniques at some point, or else they're never going to advance. You're never going to get the best type of surgery. So when I introduce a new technique, and I'm doing something new for a little while, it's nothing dramatically different, but little tiny advances, my revision rate or touch-up rate on things goes up a little bit.
Well, that's interesting because, I do about 2 facelifts a week and about 4 explants to breast a week. And I've done facelifts for a while. This is my 10th year out. And I do that, big extended SMAS. And, I've been going down to see you do a lot. And everyone's like, why are you going to see Ben? I'm like, because he does it differently and it looks really good. Right. And I'm like, I want to learn that way too. I want to be able to give my patients everything that I possibly can. And I think the deep plane facelift like you do is a remarkable, we differ, remarkable technique in certain patients.
Yeah. Yeah.
But I constantly want to learn.
Yeah, that's good. I mean, those are the best doctors. They keep changing. So you got a lot of questions. The first one that's the most important is that Kelly Colleen wants
that's my girl.
know. Yeah, well, she wants to know what it's like to be you and to be just so good looking.
Yeah, it's tough. I wake up every morning, and I'm just like, damn, again? I look this good? Yeah.
All right, so we're going to go through a Q&A now.
Yes.
Is it safe to get implants for women who compete in bodybuilding or train a lot? Because I treat facelifts a little bit differently in bodybuilders. They need a little bit more TLC in terms of maintenance afterwards, with me Botoxing things to keep their strength from destroying my neck work in the first year.
Right.
And I maintain them a little bit more. But what about for breasts and the tension and all that kind of stuff?
So I just want to make sure we know that I'm not doing breast augmentations anymore. But if I was doing a breast augmentation in someone who was super muscular, that's a tough thing because they're going to get that animation deformity. And what's that? When you flex, your breasts are going to go, and we all seen it, right? We all seen it move from the midline laterally. And so what are some of the things you can mitigate that with? Well, you can do it subfascial. So you put it under the fascia, you actually don't go underneath the muscle. And with the different cohesive implants that they have out now, you have a less chance of rippling. So my advice would be make sure you really want them. And if you do, think about doing a subfascial.
Okay, cool. So another question about rejecting mesh. And, we want to make it clear that there's a big difference between your body rejecting something and extruding it or kicking it out and falling apart versus just having an inflammatory reaction to it versus having a vague response in your whole immune system and your whole body to it. So what have you seen with the mesh?
Yeah, so depending on the mesh, I've seen a lot of women actually get infected with the mesh, and that's sort of the big issue. They're not really rejecting the mesh like you were saying, it just gets infected. And when it gets infected, you got to take it out, you got to wash it out, you got to leave it out, and then wait for 6 months or so and then retry it again. So the different meshes have different sort of infection rates, and you just got to pick the one that will work for you.
So here's one where I'm lost on. What is the surgical bra lift?
Surgical bra lift?
I've never heard of that.
Me neither.
Yeah, okay, well, we'll skip that one. We're not sure.
I'll ask Kelly.
Yeah, maybe Kelly knows. If you have an implant for 13 years, do you need to change it?
Right, so that's an interesting question I get all the time. There's no timeline on implants, right? Everyone says, oh, you need to change them after 10 years. That's not necessarily true. If you're not having any symptoms, you don't have any capsular contracture, your mammograms are fine, they don't hurt you, you can leave them in. Can I tell you that they're going to rupture? They're going to rupture sooner or later, generally. But I can't tell you when. I can't tell you they're going to rupture today, or I can't tell you they're going to rupture 10 years from now.
So if somebody is 8 years into their implant and they are doing fine, no problems, their breasts look beautiful, their body has no issue with the implant, what do you tell them when they ask you, what should I do? I heard you're the explant doctor.
Yes, I say, go home. Enjoy your life. Be good to yourself.
Yeah. So it's good that the patients know the reality of these things. And we're always
and don't let someone talk you into it. If you go to a doctor, and there's many doctors out there be like, oh, you need to change it out. Not true.
Okay, so there's a super hot girl asking you, would you ever perform a surgery while shirtless? And before you answer that, I'll tell you.
Well, that's a good question.
I've taken my gown off and like my shoes off. That's as far as I've gotten.
Would I ever operate without my shirt on? Is that the question?
Yeah.
Yeah. No.
In another country, you could actually.
Yeah. No. I know a doc who would, but it's not me.
So questions about Bella Filler Sculptra, if they make real collagen. So
I think that's a good question for you because I know how you feel about it.
Well, so Sculptra does form collagen. Sculptra is polyalactic acid, or PLLA, and it is a suture material called Vicryl that we break up into little particles, put it into a suspension, meaning it is little particles inside of a liquid, water, and then we inject it into the face, and it incites an inflammatory reaction around it. So it sits in the skin maybe about 6 months, these little particles, and your body starts to react to it. And as it does, it forms collagen in a scar form called granulation tissue or fibrosis. So I'm very happy that Sculptra exists because it does have use in patients with HIV lipodystrophy or small indentations where you can't inject fat or anything else. But I don't think it's something that should be used uniformly on everybody like it's a safe thing to do. It's definitely has a lot of downsides to it and can change your tissue quality to being more rigid wherever you do inject it.
Yeah, I mean, I think we've both seen it. Like during facelift, if someone had a lot of Sculptra or a lot of fillers, it makes it difficult. And same with threads. And I'm just going to say how I feel about this. When I talk about Kybella, I don't like Kybella. I'm sorry. That's my personal preference. I love Allergan, but I don't like Kybella because especially in the neck, dude, I've had some issues with that, you're doing a neck, dissecting the neck, and then you finish and they're swollen for so long. The lymphatics, everything has been disrupted and it's just painful.
But Kybella is brand new and it just came out and they just invented it. And it's got to be better because it's new, right?
Mm-hmm. I love what you're doing with that little micro liposuction, and that's perfect. And it's like, you're for sure going to get it exactly how you want it then. There's no guesswork.
Yeah. So is deoxycholic acid Kybella a new thing?
No.
How long has it been around? It's been around.
It's detergent. It's been around forever. I can wash my clothes with it.
Yeah, it's been around since your gallbladder has been around.
Exactly.
It's not new. It's not something that just got invented and is more advanced. That's what people mistake it for. It is a fat dissolving agent that causes a lot of inflammation, and it does have use for certain things. Very, very, I'd say here and there you can use it for certain things, but don't ever for 1 second think that it's a benign thing that you just inject. Never inject it into the face unless your doctor is saying to you, you shouldn't inject it into the face. The reason I'm doing this is because I can't get this one bump out any other way. They have a big, good reason for it.
Right. Yeah, but I've seen people this is going to be crazy, try to take out the buccal fat with it, like inject it deep. I'm just like, are you nuts? Yeah,
that's crazy. If a doctor is going to inject it down there as a primary modality to get rid of your buccal fat, you can run. There's always a reason to do something, but as a primary choice, it's not your primary choice. It is a backup choice when nothing else can be used. And it is not new. It's been around for years. We just have chosen not to use it over the past 20 years because of problems it causes. As far as Bellafill goes, Bellafill you can use. It's just, you have to look at FDA indications for these things. The FDA approval for Kybella is under here only. Smart. Okay. Yeah. The FDA approval for Bellafill is, I think at this point, for nasolabial folds and acne. Maybe. I think silicone's been removed. You can't use silicone. And Bellafill is a slightly more benign form of silicone, I'd say, if you want to classify it as something. But I personally don't use it because I have trouble predicting what it's going to do, but I've seen very good doctors do the tiniest amounts of it. But these are like super skilled guys, There's not like your regular injector who's gonna open up it laser away or something.
Easy. I'm a medical director at Laser Away.
I'm just saying though, you're not gonna have those guys injecting Bellafill, right?
No, totally. They're super safe.
Yeah. This is like a specialist. So like Hayworth, I was talking to him yesterday. Like,
of course.
Okay, I'd let Hayworth do it.
Right.
Because Hayworth can fix. He's seen, he's a revision specialist, but by no means should you get Bellafill injected by somebody who is not a super amazing surgeon, because things go wrong with injections, and if you can't fix it easily, you got a lot of problems.
And I think that goes for fat too. Fat is not as benign as people say it is, right? So both of us do a lot of fat to the cheeks and sort of everywhere, but also do a lot of fat to the breasts, right? It looks great.
There's your question right there.
Thoughts on fat transfer to the breast? What kind of
complications? So continue what you were saying.
Well, so years ago they thought that putting fat into the breast would cause, which it does, cause microcalcifications, and those microcalcifications will be mistaken for cancers. Mm-hmm. So that has been dispelled. Radiologists are smarter than what we thought they were, so they can actually tell the difference between what is what, which is wonderful. So the fat transfer. I do it so much. The issue with fat transfer is that you can't get a large volume in, or I don't do a large volume because of fat necrosis, lumps, and bumps. So I'm conservative with it. Because of that, more than likely, you're going to have to do more than one round of fat grafting. Because if you say 30%, 40% gets absorbed by the body, you're left with 60%. So you're going to have to do a couple rounds to get to that 100% to give you a cup size and a half.
Well, so the next one's actually, I don't like financial questions in general because they're not so helpful.
No, that's a great question
for us to explain, but I'm very curious about this given its implications.
Right. That's a great question. I hear that every day. Does insurance cover my explant? At this point, no. Why doesn't it? Because it doesn't have an ICD-10 code, right? No one has yet said breast implant illness is actually a thing. That is going to change. So that's actually closer to getting a code. Once it gets a code, then it might be able to be covered by the insurance company. What will be covered by the insurance company is, grade 4 capsular contracture, pain in the breast, and things like that, which can accompany breast implant illness.
All right. So here's a question that if your daughter or sister wanted implants, what would you tell them? So
no.
I can answer that one. Well, let me answer too.
Okay, you answer that one. Yeah.
My sister's like watching, so she's no. So it means like if you really, really cared about someone, what would you tell them?
Right.
I think breast implants are okay to get if they really want to, enhance the breast size. Do something very subtle and natural. I think it's fine to do. And again, I'm not looking at it from the breast illness side of things. Assuming that's rare, I would say, most of the world is fine with these things. And if you do something small and natural, you're okay. Now we ask the man who is taking...
Well, I think that's a little bit unfair, right? Because everyone knows my answer. I would say no, right? I would say, and I tell my patients that. So, I still get breast augmentation patients, and I tell them to come in and so we can discuss, right? I say, listen, if I think we can't achieve what you want with what I can do, go to my partners, my man, Dr. Nate Villanueva or Dr. Orden. Either one of them still do implants. But for me, I'm only going to put in fat or give you a lift. If I can't achieve that, it's up to you. And I tell you all the risk and benefits, and you're like, I still want it. You can go to somebody else and they can put it in for you. Even, your boy, Dr. Cohen, he's a great surgeon too. He can put him in too.
He does great boobies.
Yeah, he's a wonderful surgeon. So, I think there's a lot of guys out there that can do him. I'm just not that guy.
Yeah. And so this is another thing I'm curious about, because I think even seeing Eden go through this, she had a pretty quick recovery, I'd say, from explant. So I feel like from what I've seen, the recovery in terms of going back to your life is quick, but it takes a long time for it to settle, no?
Yeah, that's it. Everyone asks me how
place and touch up and do.
Well, not even that. Let's just talk about symptomatology, right? Mm-hmm. There's some women who will feel good in 2-3 days. They'll feel like my eyes feel better, which is interesting because implants for sure are proven to cause dry eyes. So when women, uveitis essentially. So
repeat that. That's for sure.
Yeah. So there's definitely documentation saying implants will cause dry eyes, and people will recognize that. Okay. So when implants are taken out,
are they rubbing their boobies on their eyes?
I don't know what they're doing, but they feel better with that. When do the symptoms get better? So some, like I said, get better in a week, months, and some don't get better to a year or so, right? But that's combined with being healthy, eating a good diet, exercising, sleeping, all these things, add up. But yeah, so, and then there are a small subset of women who just don't feel great. A couple of the symptoms go away, but the majority are still there. And, we're not sure exactly why that happens.
Okay. And 10%, you said, out of your 90% success rate, the other 10%, you'd say just...
They don't feel any worse, but they're not getting better as they should.
Okay. And how long does it take the breast to look good again after the explantation? Do you have to worry about proper contracture or settling or softening?
So the ideal candidate for an explant is a patient who may need a lift, who has a ton of breast tissue, who have small implants that are over the muscle. That's going to be a home run for me. I can lift them. I can, change some of their architecture of their breast tissue, and they'll look wonderful. They will look wonderful in, 3, 6 weeks, they'll look really good, other than the incisions. And then we go to the women who got breast implants because their breasts were small, they didn't have any tissue. Those ones are very, very difficult because usually when they have not a lot of tissue, they don't have a lot of fat, so we can't do a lot of fat transfer. So those women are very difficult because when we take out that capsule or that scar tissue, what happens is that scar tissue, I should say that breast tissue adheres to the chest wall. When it adheres to the chest wall, it looks terrible. The only thing we can mitigate that with is putting a little sort of buffer in between, which is fat.
Okay. All right. Awesome. All right. So we're getting towards our time now. So I would say for anybody who wants to consult with Dr. Chopra, if you're having these kind of problems and you want to see if it's possibly happening to you, remember you got to go through a workup first, make sure there's not other things causing this. And you definitely, I'm sure, find other problems when patients come in with hormone levels, and I'm sure you've uncovered things before, no?
Absolutely. So, but that's an important point. We kind of glossed over that. If someone has an autoimmune issue going on, they shouldn't have implants in, my personal opinion, right? Because their body is already fighting themselves. What are they going to do with a foreign body in them?
All right. So if you guys want more advice, you can contact Dr. Chopra. His Instagram handle is DRRITUCHOPRA. And website, what's your website? It's Orton Chopra?
Yeah, that's right. Orton Chopra.
OrtonChopra.com. And he's going to be on TV every day forever, so you can always just watch him there. He's a very, very smart guy, and we're going to do another one of these things soon with more specific questions once we have them, and hopefully I'll see you back at the office like very, very soon.
Yes, brother, I miss you, man.
Soon enough. All right.
All right, take care.